Okay. I think we'll get started. So thank you. We'll start. Muted. Muted. Okay. I think we'll get started. So thank you all for coming. I just muted all the participants just to reduce the echo, the background, the noise. So I'll give a brief update. Then we're really pleased to have with us today Dr. Asad Latif and Dr. Berenholtz, who've been fundamental in getting this project moving forward. And they have been the leader on the CUSP project in the United States. They will be with us in this webinar. We have a presentation on establishing the NASAM team, the 5 steps for CUSP. And then we're going to have presentation from Dr. Hasan Al Ashi from Asir Hospital. He's going to review his experience in data collection, and has been doing a great job, and we're really very pleased to have him with us. So just a brief update on the projects so far. We have so far 73 ICUs participating in the project from 48 hospitals in 27 cities, which is really remarkable, and we're really grateful to everybody participating. This line, I removed the names of the hospital because that's not objective, but in green, these refer to number of weeks that people have collected data and entered data, and in red are the ICUs that have not entered any data yet. And we would like to see less red and more green. Eventually, hopefully, all the ICUs will contribute and put data. So this is a different way of kind of dashboard. So I thank Iman and Cheryl and Abdullah and Muhammad for collecting this, and Bashir, also Dr. Bashir now joining us from MOH for tracking this. So this is per week. We have maybe 60% of ICUs have collected data last week, for example, but there are some ICUs don't have data yet, and we would like to see this improving as we go along, but as soon as possible, please. It's important. So with this brief update, I'm gonna turn the microphone to Dr. Asad Latif and Sharon Berenholtz. And so let me just unmute the mute. How to mute this? Asad, where's Dr. Asad? Is Dr. Asad with us? I see, Sean, I unmuted your microphone. I don't see Asad.
Yes, let's keep looking. He's definitely there. I just talked to him. Asad, are you on mute, friend?
Asad here, okay. Asad, can you hear us, Asad?
Asad, are you on mute?
Asad, can you hear us?
He said he can hear you.
Hello, can you hear me now?
Yes, Asad, now I hear you. So,
thank you. Somebody had muted me. Not on my end.
I'm in the conference.
Dr. Arabi, thank you very much.
Our red or green?
Green. Would you be able to load the slide, Dr. Arabi?
Yeah. Okay, can you see the slide now?
Yes, thank you very much. And thank you everybody for being on this call. It's been very exciting to hear about the tremendous progress you all have made and in terms of setting up NASAM and the tremendous effort Dr. Arabi and his team have made to make this possible. So I just wanted to start off by acknowledging that and applauding them. Our understanding is some of you were there for our launch workshop back in November, but not everybody was there. So we're going to go over some of the critical aspects that are supposed to go hand in hand with the technical work that you've been doing in terms of setting up
Because
the
she's
data
still on the
platforms
group,
and trying to
Layla.
collect your data. Next slide, please.
You have to remove her if you want.
Can we go to the next slide?
Okay, Asad.
Yes, Dr. Arabi. Can you go to the next slide, please?
Next slide.
Sure. So this critical next step is really setting up your CUSP team. Well, CUSP stands for the Comprehensive Unit-Based Safety Program, which is really an intervention in and of itself. And it's a different type of intervention, though. Not technical, but more adaptive, which is designed to learn and help you create a team that can learn from mistakes and improve an elusive concept, patients, the culture in your unit, so that the culture becomes one of learning, one of improvement, and one of that ultimately benefits the patient. It's really designed to improve patient safety awareness of problems while they occur, before they occur, so that we can respond to them in a much better fashion. And to help mobilize and involve your frontline staff in becoming part of the team that helps bring these initiatives like NASAM to fruition. And the goal, what we're going to do there over the next 15, 20 minutes is really go over the steps that are involved in this adaptive intervention and to help maximize the benefit of enrolling your team and applying the key principles that you are going to learn about, minimizing mechanically ventilated pneumonia. Next slide, please. Ultimately, why is culture so important? Because it turns out there's a good amount of research that shows that the safety culture of an organization is a measurable quantity, and there are various tools, and you will be asked to participate in some of these patient safety surveys that have been validated in Saudi Arabia from our previous work to measure the culture of your unit, various domains that incorporate that. And ultimately, we know that the culture for an organization is really a product of all the group values, the attitude, the perception that people have, the small stories that people think about whether things will work or not, and their approach to things that ends up actually having a tangible effect on patient care and patient outcomes. We all understand this intuitively, but often we feel to operationalize this very critical component or an adaptive strategy to improve this important aspect, instead focusing primarily on technical components. And we know from the science that this is far less effective. Next slide, please. Here's a conceptual framework that we really operate under, and NASAM is also following. This is based on our CUSP program and CUSP for MVP, where the baseline of everything is measurement. Measurement is the baseline of improvement, because if you don't know where you are, you won't be able to improve. But then you see the two parallel and equally important aspects to improve, which are the technical work. Specifically, in this case, we are focusing on mechanically ventilated patients and ventilator-associated pneumonias and harm, but also the parallel arm of technical work, which is the CUSP team that you'll create, a program you follow to help implement those arms that leads to improvement. It's a conceptual framework. You, of course, might have seen this before, but the idea is, starting off with measurement, you need both things to ultimately improve and be able to improve on the continuous feedback cycle. Next slide, please. So, like with any good and lasting work, there is some prep work involved in being part of NASAM. You've done the first aspects, which is create the data culture, the data platform, and start implementing in your unit. I was very impressed by the fact that more than half the units are already collecting data and submitting data, which is fantastic. The next step is really creating a CUSP team. and we'll go over what the steps are and who should be part of it. And then working with your existing resources, identifying them, such as your quality office, for example, and your hospital leadership, to make sure that you have all the resources you need for success. Start off with one ICU, with one unit that's eager, willing, and participatory, as opposed to starting broad. So one theme you'll hear over and over again is start small if you have to, and then expand, rather than starting too big and then failing so that people don't believe. NASAM is a fantastic example of that. Dr. Arabi and his unit sent a small cohort of about 12 ICUs in Saudi Arabia were the seed that helped develop NASAM, as they were part of a larger cohort with Dr. Berenholtz and the CUSP MVP program in the US, which had several hundred ICUs. And Dr. Arabi took the lead and involved a small core of 12 ICUs within Saudi Arabia, which showed for the first time that multiple ICUs from different sectors could work together and also were able to affect outcomes. So we started out small and now we're expanding. We urge you to do the same. Next slide, please. The keys to something a custom team are really to understand that your safety culture is local. And by local, I mean the level of your unit. What works in one ICU in your hospital probably doesn't work in the other ICUs exactly the same way. For example, in our hospital, we have surgical ICUs, medical ICUs, cardiac surgical ICUs, CCU, which are physically next to each other, but every unit has a different team, different culture, different approach. And lo and behold, if we try and take the protocols we develop in our surgical ICUs to our medical ICUs, it involves a little bit more than that, and understand that culture is local. And our team needs to really compose of engaged frontline providers who will really take ownership of patient safety. And sometimes you have to really look for those people. But it's surprising how many people, once approached and given voice, are eager to speak up and be part of these fantastic projects. And we also urge you to include people with different levels of experience, not just senior people. They have a very critical and key role, especially in Saudi Arabia, but also junior people who will help provide the energy and do the brunt of much of the work. Next slide, please. So the team composition is critical in a custom team and involves multiple layers. The broad strokes, a team leader, which we found might need to be more than one person. Often it's a clinician, but there are other team members that we'll go over that are equally important, if not more important, in such settings. Champions, such as the nurses and the physicians or specialists who will be able to do the day-to-day work under the support and guidance of the team leaders, as well as local opinion leaders, who often end up being critical in getting many of these new approaches or policies adopted in the unit. It might not be the person who's the most active shows their meeting, but it might be the person who can potentially stop things before takeoff, or whose opinion matters in your organization. Sure, we all have many of these positions and leaders within our units. And of course, people with diverse opinions. Next slide. So what is the right size of a CUSP team? Well, there's literature on showing what the size of teams are that are effective. We know that teams that are smaller than 6 are often unable to carry a task, and teams that are bigger than 11 or 12 end up being too large and unwieldy. Somewhere between them ends up being a soft spot. Multidisciplinary representation is critical, and we really urge you to consider that when you develop your CUSP teams. Highlighted in red over here are some critical roles that, from our experience, are probably the bare minimum of people who should be involved. Some of these seem complementary, like the physician, ICU director, and the nurse manager for the unit, but also separate from them, a nurse champion, who might not be the same person, but somebody who's going to be energetic, enthusiastic, and do a lot of data work, as well as a physician champion, who might be different and probably should be different from the ICU director. Along with them, in a specific project like NASAM, where we're focusing on ventilator-associated harm, between the respiratory therapist and the physical therapist ends up being critical because their input and their execution of and buying into many of the policies that are going to be implemented is going to be critical. Another key team component that we found is really your medical director, executive champion. Whether it's your medical director of hospital, the CEO, our work in the past has shown that these roles end up being critical. And this is between different settings. When we did this work in the US, working on venereal-associated harm, on ICU infections such as central line infections, we also took a look informally at what are the teams that are more successful than others. And we found two key themes. One was teams that actually met more than 80% of the time ended up being more successful. And B, teams that had certain compositions were more successful than others. The composition really differed between work that we've done in the US, for example, and more in the region or different cultures like Pakistan, where we found that it wasn't this meeting, but it was teams that had the three different types of teams that had physician champions and executive champions both show up to the meetings. And we found that teams that had both of them show up more than 85% of the time had high success rates, whereas teams that only had one of them show up and the other one show up less than 50% of the time were not as successful. So the executive championship ends up being critical along with the physician champion. And we can guess as why, right? Often our cultures are a little bit more hesitant to implement change. And really enforcing that ends up being critical in the first, especially at the NASAM stages. Having people involved and show up to meetings gives that right signal to the front line that yes, this is important, and yes, this is a key priority that we should focus on. Next slide, please. So, CUSP is an actual as prescriptive as these sort of programs can be. It involves 5 key steps, which we're going to go over in detail. Next slide. Next slide, please. So the first step is really creating a common baseline and understanding within your frontline staff. We've done this in the past by educating them on a principle we call the science of safety, which really is focused on helping people understand that safety is a system property and there's a systematic approach, providing them that system lens. Not everything is, this we found is the first step in helping change culture. Often what people end up thinking and what might be happening in certain places is that culture ends up being more individualistic and blame dependent. We think that people drive and their effort drives results. Whereas we know that it's not just individuals, of course, they have some responsibility, but it's the system around them that sets them up for success or for failure. So providing even frontline staff who work in the unit, everybody from the nurses to the physicians to, in our units, our techs, are provided that sort of baseline training or learning through and viewpoint through indoctrinating them with the science of safety. And which really focuses on the principles of safety and the key components of which are to standardize, create independent checks, and learn from mistakes. And applying these strategies and how that they adapt to this whole concept of technical and adaptive work. Next slide. The key often ends up being having a definitive plan on making sure that everybody is educated in the science of safety and is able to see this sort of educational video. What we have developed on our end is an educational video, ends up being about in the 20-minute range, which talks about this concept of key principles. While we were in Riyadh last at the NASAM workshop, Dr. Arabi, Dr. Zahir were kind enough to be willing to take the lead in translating this to Arabic. And we can talk about that as we go on, Dr. Arabi, but that might be something that's useful for some staff, whereas English might be more appropriate. But also key is, along with the language barrier, making sure that you have a documented plan how to make sure that people A, view it, and B, new people view it as their staff turnover occurs. In our units, our staff averages nurses turnover in about 1.8 or so months, less than 2 years. So we found that including it in our credentialing process as a requirement ended up being a key component after our initial wave, in which we got every staff by screening it at the unit level staff meeting. You will have to come to your own methodology for incorporating this, but this ends up being a key component to show people that, especially people come from other places, that this is a key principle that we are investing in. Next slide. The second step of CUSP is really to be able to identify defects. And by defects, we mean something that is going to occur that affects your current project. There's various ways that people can do this. Whether it's through your existing M&M data or from your existing harm data, which can be cumbersome, especially in units which don't do this routinely. Another tool that we're going to talk about, not today, but probably in our future call, is the staff safety assessment, which ends up being a very simple tool that we've adapted for this project, which asks people two simple questions. How will the next ventilated patient be harmed? And B, what would you, as a provider who works here, consider doing differently to prevent this from happening? It turns out that these two very powerful questions, while simple, end up providing a lot of insight into how people think and what people think the local problems might be. And we found this to be very powerful in helping suggest locally relevant solutions, as opposed to using one size fits all, providing that local flavor that often identifies problems, what's the most highest priority in your unit, and B, also identifies the best way to go about solving. Next slide. And the steps to involve listing all the defects that come up around the problem of mechanically ventilated patients. And we also have a framework and a tool that when we go over it, we provide more detail about how to prioritize the solutions, which really focuses on two things. What is a high impact solution, as well as very feasible, because you also want to make sure that you have something that is possible to do. For example, people talk about how different type of ventilator might be more practical or prevent harm, or having certain solutions might prevent harm, but procurement often ends up being beyond the scope of local teams. But there are other solutions that might be far more relevant and practical, such as one team I saw, somebody suggested putting level measures or taping the sides of the bed because their beds didn't have them, and they were unable to know accurately whether heads of beds were over 45 degrees or not. So simple solutions that are more feasible, doable. It's surprising the type of things that you can come up with. The final key component with this is really, after getting their feedback, is providing the people who provided you these ideas with their identified defects, with the feedback in terms of transparent manner, in terms of what was discussed, what was provided, how it is prioritized, as well as what you're doing about it. Because we found that people will often be very eager initially, but that eagerness might fall by the wayside, as does their participation, if they don't get feedback about what is done with their thoughts and ideas. Next slide. The third, probably in my opinion, what's the most critical steps for CUSP is finding an executive partner. And I know in many ways, many of you have found them, others are working identifying it. Dr. Arabi and the NASAM team can be critical partners in helping secure this sort of formal partnership. And this sort of partnership really has to be participatory. It's not just on paper, but what we advocate for is having the executive become a true member of the CUSP team, attending meetings and such. As mentioned earlier, we found that teams that have them come to the meetings end up being more successful, far more successful than teams that don't. And there's various reasons for this. It helps provide shared accountability during the monthly review. They might or might not be key instigators of the clinical processes, but they help keep people accountable. And it's not just you who, of course, are already being over here, but often within the larger unit, in the larger organization. Next slide. It is challenging, and I'll be the first to admit that it can be challenging to find an executive partner because many of them may lack clinical background and may not recognize the value of patient safety in using a formal framework like CUSP to help improve. But these are all things that, if we anticipate, we're able to work around. For example, one of the units we worked with, we actually we provided them a basic filler. Our IC director went there, provided them a basic understanding of what the clinical problem was and what we expected their role to be in terms of participation and encouragement for the rest of the team. They ended up really responding to that and being the ones who asked in every meeting, oh, so what is our CLAPSI rate this month? And just having them ask that ended up being a powerful motivator. They got so engaged that ultimately, as our rates improved, they started taking them to the board of directors and showing that, hey, this team that I'm part of ended up doing this much better in infections this month than last month, and help celebrate many of the successes, such as harm-free days within the unit. The other thing we had to do, though, to ensure that was talk to their secretary, who actually controlled their schedule and book appointments for the whole year in advance. So there's various ways that we'd be happy to share in terms of executive engagement, but we found that identifying the challenges ends up being critical, and hopefully we can preempt many of the challenges that might occur given our shared experience. Next slide. And like I said, there's many keys to engaging senior executives, such as acknowledging what's in it for them. I told a story about how one of our executives really wanted to participate because they want to present this sort of data to the board and show that their visibility increased. And their visibility within the unit helps increase, and it was very important to them. Often, it's surprising how many of them are non-clinicians and really don't understand our clinical world and can be very appreciative of FaceTime with frontline staff. Next slide. The fourth step is an ongoing step and possibly one of the hardest to implement, which is learning from mistakes. And by this, it's really learning from mistakes on a continuous basis and doing it in a formal manner so that you're able to not only learn, but also improve based on them. So whenever we learn from mistakes, we actually have a specific we advocate for. We'd be happy to share. In fact, I believe our second call this month will be focused on this specific topic of learning from defects and sharing that tool with you. But basically, every mistake should prompt 4 questions and having those 4 questions answered. What happened? Why did it happen? What can you do to help reduce the risk in a measurable way? And how will you know that the risk was reduced if you revisit the same issue in 6 months? Next slide. And there's many examples of defects or things that you don't want to happen that can affect patient safety and ventilator associated patients. Here are some examples of simple things that were addressed from different projects that we've worked on. But it's interesting how the interventions, if you note, end up being multifaceted and can involve multiple layers. For example, the unstable oxygen tanks on the beds seems like a simple enough problem, but something that ended up being, because the solution was to get new oxygen holders installed throughout the hospital. But you can imagine the type of effort that took, identifying and working with our environmental engineering department to identify the right brand, working with having the physician champion advocate for it, having them work with the executive champion to procure the funds, and then be able to buy them for the whole hospital. But that wasn't the end. We also needed to work with the nurses to make sure that they were installed in each bed, they were removable, and then to make sure that the culture changed to never use a bed which didn't have them. So it ended up being a very involved process that required many, many different stakeholders and levels of involvement. Next slide. The final step of CUSP is really working on your teamwork and your communication. We have various tools that we will share with you, but ultimately, these teamwork tools end up being critical, especially focused around the problem that you're trying to address. Examples of this really are things like the daily goal sheet, and shadowing we found is a very critical and useful tool in helping people get on the same page around the clinical focus. In this case, ventilator-associated pneumonias. Next slide. It really does take culture to get the most out of best practices. Often, we all know what to do, but making sure that it's done each and every time for each and every patient ends up being difficult. I'm sure many of you are aware of the surviving sepsis guidelines and how it involves a few simple steps, but multiple efforts to try and improve and implement these sort of guidelines with the 5 or 6 steps show that having 100% compliance with every step is almost difficult, is almost impossible. And often, once you get over 5 steps, compliance hovers in the 25 to 30% range. There's multiple examples of why culture is important. I'm sure you're also familiar with the WHO Safe Surgery Checklist, which is one of the initiatives that is often mandatory in many places, and its use has been shown to decrease morbidity and mortality by significant margins across the world. What people don't often notice is there's a subsequent paper which showed that there was a difference between the units that performed well and the units that didn't perform as well. And almost half of the benefit could have been predicted from the safety culture of the units when they started. That's a very powerful tool, and we need to think beyond standards and beyond the checklists to really get the most out of best practices. Next slide. Next slide. There are some basic lessons that we've learned, and we hope that we continue learning about as we embark on this journey with you. Culture is local and often down to the level of the teams and the units themselves. This is not a linear process or fight that we're engaged in. It's an ongoing iterative process. There's going to be repeating cycles. Sometimes we'll do better, sometimes we'll do worse, but we will be in this together and to help guide each other on this longitudinal journey. And finally, having the CUSP team is most effective when it's coupled with a specific technical problem like ventilator-associated harm, and gives us an opportunity to practice the teamwork, the structure, and the tools that we will be focusing on over the next several months. Next slide. Next slide, please. And with that, I'm going to leave you with this quote and Dr. Arabi, I turn it back over to you. If Dr. Berenholtz has any words, please go ahead.
Thanks, Asad. Sean, thanks everyone. Asad, great job. You know, I think, you know, as I listen to this, you know, a couple of things kind of stand out to me. You know, I think that, you know, as Asad kind of described, our experience in the patient safety movement over the past 15 years, ballpark, right? That to achieve significant improvements, we need to focus both on the technical work and the adaptive work, and we need to do them simultaneously. I think many of us focus on the technical work, right? We're clinicians, we're well aware of the evidence-based practices for preventing harm for patients on the ventilator, but to be successful, we also need to focus on really that adaptive work, as we've been describing in this talk. You know, we can spend time creating policies and protocols and procedures and checklists to help ensure that patients are getting those evidence-based therapies they should, but to be effective, we also need to, for teams to really use those protocols and checklists, we need to make sure that we impact the values, attitudes, and beliefs on behalf of our frontline staff. We need a mechanism for our frontline staff to feel like they have a voice, to help them feel heard, to help them feel valued, to help them feel engaged. And this CUSP program, or the Comprehensive Unit-Based Safety Program, is perhaps the best validated approach to improve teamwork and safety culture on a large scale. When people talk about efforts, you know, we've done a number of state and nationwide efforts now focusing on reducing healthcare-associated infections. And when people talk about the success of these programs, they often focus on the checklists that have been developed and have been widely disseminated as a result of these efforts. But anyone close to these efforts will quickly recognize that there is no one checklist. There is no best practice around the checklist. In fact, checklists vary widely depending upon what unit you're in, what your local culture is, what types of challenges that you're able to identify locally. So really this is about moving past the checklist and really starting to work toward creating an infrastructure or capacity within our local ICUs to not just address ventilator-associated harm, but other areas of preventable harm as well. And this, as Asad described, this CUSP program, you know, I just want to highlight a couple of things. You know, obviously educating staff on the science of safety is exceedingly important. Many times when something happens, patients don't get the evidence-based therapies they should, or mistakes occur, then we focus on individual providers. But the reality is that it's really, safety is really a property of the system. If patients aren't getting the therapies they should, head of bed, spontaneous awakening trials, spontaneous breathing trials, that oftentimes is not the result of an individual provider. It's not the result of one doctor or one nurse who just isn't being vigilant or isn't doing what they should, but rather we really need to start to develop these system lenses to help see why it is it that patients aren't getting the therapies they should. Oftentimes it's not because of individual providers, but it's rather because of the system that we have. So CUSP helps us dig into this. CUSP helps us to be able to see these system level lenses and to partner with senior executives to begin to address these defects. And the defects, as Asad talked about, as mistakes from liability claims, for example, or HAI rates. For this project, you can think of a defect as any time that a patient is in our ICUs, they don't get the spontaneous awakening trial, they don't get the spontaneous breathing trial. This is a powerful opportunity for us to begin to learn from those mistakes and to be able to address those to try to help improve and ensure that patients moving forward get those therapies. So Asad, great overview of the CUSP program. Very interested in hearing Dr. Arabi's thoughts, or team members, what questions you have about this CUSP program, because throughout NASAM, we hope that you will be focusing not just on we hope that you'll be focusing on both the technical work, those evidence-based therapies that patients should be getting, but also simultaneously working on this CUSP program to begin to practice some of these new skills and new tools to help improve care for ventilated patients. Dr. Arabi?
Thank you, Sean. Thank you, Asad. So really, this is a great discussion. So the message that I get from this presentation discussion that there are certain practices that we should be applying to mechanically ventilated patients to improve their outcomes. And this is the technical part. We know that we need to raise the head of the bed. We have to implement spontaneous awakening trials, spontaneous breathing trial, subglottic suctioning. So this is the technical skills. But what you emphasized also on the adaptive part of the project is that for us to be able to implement this, we need to form each team has to, each unit should form a CUSP or a group of people, professionals who work locally to improve things, because the change can happen only from within the unit. It's the people within the unit are the ones who are going to drive the change and make it better. So you outline clearly how to form this team that should be multidisciplinary, physician, nurse, RT. I mean, in our example, the NASAM, which is mechanical ventilation, I think these are the critical three groups. The physician, nurses, and RTs have to be on board. And we have examples actually of ICUs. We're going to hear from Asir Hospital, a great example of CUSP. Dr. Hasan going to talk about this. And we have other examples when some members of these teams, some of the units where the multidisciplinary team was disengaged and it didn't work. And we are trying to, if we have to get the team working together for this to succeed. So this is really great overview, Asad and Sean. I think this is really very helpful. So if it's okay with everyone, I would like to move for interest of time to Dr. Hasan Al Ashi. Can you unmute?
Good afternoon, everyone.
So Dr. Hasan is presenting from Asir Central Hospital. And if I understand correctly, I'll let you, Dr. Hasan, introduce the people who are attending with you, because we're really happy that you are getting all the support from the director of the ICU and director of the hospital. This is really remarkable. This is exactly what Dr. Asad Latif talked about. This is exactly the point. So really happy about this. So go ahead. We have 15 minutes. We like to finish by 3 o'clock sharp.
Okay. Yeah, good afternoon, everybody. Really, as you said, Dr. Yaseen, we have big support from all the administrative here, starting the hospital director, head of department, all the ICU consultant, as well as all the ICU staff. I want to welcome all our, let us say, NASAM family. It is not NASAM team, it is NASAM family. Our ICU consultant, ICU specialist, resident, and all the ICU nurses and the respiratory therapist, physiotherapist. I want to specify Dr. Muhammad Bahis. He's with us, our ICU consultant, Dr. Amir Asiri, our ICU consultant, and Dr. Abdul Menaim, ICU specialist, and also our brilliant hard worker, physiotherapist Sarah, and our also brilliant nurse, Sister Nurhaya. Welcome all. Please, let me start. Yeah, when we start to have a NASAM, to start the NASAM project in our ICU, we think about difficulties and how the process of the work will go on. So we organize this, the ICU NASAM daily data collection sheet. So we are going daily, almost 1 or twice per day, to be sure that the data which collected is accurate and there is no any mistakes. So we'll start from the bed of the number of the bed of the patient, if he's mechanical ventilated or not. Location of intubation. Can we go to slide number 3, please? Yeah, this is an real round, daily round for the NASAM team. For example, location of intubation, we will write just a number, like because we summarize the list. that if the patient intubated in the OR, he will take score 3. If intubated in other hospital, 2, in our ICU, 0. Just we will write number. Then when we are going to enter the data, there will never be a mistake, and we will gain the time. We will not waste the time to show that list. Then we will choose it. Okay. Then we will go for the other checking for the NASAM daily round. In the sedation vacation, from the first day of the NASAM project, we make the sedation vacation as a part of the patient care. It is not a procedure, it is not an option. All the nurses should switch off the sedation at 7:30 sharp time, unless there is order written by the specialist handling the patient on the night duty, that he should write clearly in the file that do not stop the sedation. There is no sedation vacation for this patient because of this reason. So it will be clearly mentioned in the file. If there is no order to the staff nurse not to stop the sedation, she will stop the sedation automatically at 7:30 for all the patients. So this was our solution regarding sedation vacation. We give the chance to the sister to decide and to do so. For the spontaneous breathing trial, all the patients, we make as a rule. With the RT team, all the patients who get off sedation, they should receive spontaneous breathing trial unless he saw that he cannot continue with the sedation vacation. If the sister informed him that she cannot continue because of agitation, other cause, so they will not do spontaneous breathing trial. Otherwise, spontaneous breathing trial will not be an option. It will be a daily practice for the regarding the patient. Also, can we go to the other slide, please? Yeah, the next also. Next. Yeah, here we make this our NASAM daily round code. This will be with us that if the patient has any contraindication of head of bed elevation, we will not write like hypotension, unstable, no, we will write number. This will help us also that if any cause not mentioned in this list, we have to determine why this patient was out of head of bed elevation procedure. The same for the sedation vacation, the same for the spontaneous breathing trial, that we have to know why this patient was not received sedation vacation, and the cause should be documented clearly in the file of the patient. Next, please. Yeah, regarding the VAE forms, we also organize this form. This is our daily round form for the ventilated patient, tracking the ventilator parameters and the ventilator event. In this form, the patient ID will be there, the date of admission, from where the patient came, where was the intubation, status, where is he in the ICU, discharged, or the patient alive. This is daily checking. Patient code, when we are filling this form, and there is an VAC or IVAC or BVAB, so we will screen the form, we will scan the form, and we will send it to you. So to keep the patient information secure, we will give the patient code. For example, patient code number 2, that this is the code will be sent to you. But in our data, we have that patient code 2 means the patient name, for example, X, and his file number is 111 like this. So anytime we can review the data of this patient, that patient code 2 means this patient, we can get the file, we can get the forms, we can get all the information about this patient. Can I have the next slide, please? Okay, so this is a real patient data collection. We just hide the patient the information, the name of the patient, the date of admission, the file number, and the status. Because the status we are writing, if he's in ICU, we are writing the ICU, which bed, and what's the status of the patient. So in this form also, we can, like the next slide, please. Yeah. For example, this patient, if he is having a VAC, increase in the parameters, in the FiO2 more than 20, or in the beep more than 3, so we can determine here that when the WBC increased, which day the fever was, and which day the antibiotics or new antibiotics was started, and what about the culture, send or not send, which date, and we can also trace the result of the culture. The next, please. This is IVAC, real patient. We are making also an electronic form we are filling, and this is the form we are sending. You see in the subject ID, we are writing 02. 02, this means the code of the patient. So we have in our data what 02 means, which patient, what's the name of the patient, what's file number, what the file number of this patient. So I can trace this patient anytime to be able to analyze the data, why the VAC or IVAC or BVAP happened, where was the mistake, where was the defect. Next, please. Yeah, this is also another example for patient who is having a VAC, but positive VAB. Also in our ICU, the same for this patient. Next, please. Okay, next. Okay, for the physio, I want just now to give the chance for our physiotherapist, Sarah, to speak about her experience shortly. In the physiotherapy, we started to do something that we are making on a card. In this card, all level of mobility is mentioned. So the physicians, during the morning round or the daily round, they will say which level of movement or mobility they need for this patient or suitable for this patient. So this will make a patient safety situation that patient will not receive mobilization higher or less than the suitable for him. This will be also an illegal for our the physiotherapist, and it will help her. I will let her just speak, if possible, Dr. Yaseen, for like 1 or 2 minutes about her experience. Is it possible?
Yeah, 1 or 2 minutes, and then if we can have comments, final comments from Sean.
Okay, okay.
Yeah, 2 minutes, please. Yeah, go ahead. Yeah, Dr. Hassan.
My name is Hasan Al Ashi, physical therapist. My experience, I started from early mobilization protocol for ICU patients. It's under ICU consultant supervisor. Every day, I reassess all my patients about mobility. Then I take some consultation from the doctors about the level of or highest level of mobility. Some doctors give me where's the patient. For example, if the doctor wants the patient to be at grade 2, I try to enhance patient to be in this grade. Sometimes no, we start with patient from 0. Every day I have schedule for my patients, the same schedule for Dr. Hassan and other team. It's contain of bid number, the highest level of mobility, the barriers of achieving higher level of mobility, if the patient needs physical therapy or any if we have any adverse events at physical therapy session. Until now, we didn't have any adverse events. Some patients, alhamdulillah, we get more, maybe 6 or 5 of the highest level of mobility, and we complete in this manner. Thank you for Dr. Hassan and my team. Thank you for you also.
Thank you very much, Sarah. Great job. This is fantastic. Really remarkable work, and what you are doing is really impressive. And this is a good example of successful CUSP, where you have the doctors, nurses, RTs, physiotherapists, working with the administration to get this quality improvement initiative working. Can I have final concluding comments from Sean? What do you think?
Yeah, sure. Thanks. So great presentation. Thanks for sharing. I love the interdisciplinary kind of engagement. I think is really important. Again, I can't stress enough. I think that, you know, by default, we're all going to be focusing on kind of these technical components, right? Trying to get head of bed elevated, SATs, SBTs, you know, all these technical components, without a doubt, because that's kind of where our training is. But I can't emphasize enough the importance to begin to work towards some of these CUSP steps and CUSP components to begin to better engage our frontline staff and to help them feel like the work that they're doing is meaningful. I think it's really about staff engagement and helping staff feel like they're valued and playing an important role that's going to help our teams move forward amidst, you know, undoubtedly staff are very busy. There are many competing priorities. And I think it's through this type of engagement that we move away from staff finding barriers and, oh, we can't do this, we can't do that, to help them feel like they're more engaged. And I think that's going to help us move forward. This CUSP idea, without a doubt, for many of us is very new. And I don't think that we can do a very good job of really kind of walking through these processes on this one webinar, right? For many teams, this CUSP journey takes years. So I hope that you'll continue to keep this on your radar screen, share with us where you're at in this process, how we can better support you around this CUSP project. You know, I think between now and next call, for example, I would really focus on, we'll talk to Dr. Arabi and the leadership team, focusing on educating staff on the science of safety and starting to identify defects, starting to tap into that wisdom of frontline staff. As Asad shared, that second step of CUSP, follow the next patient be harmed. One thing I think that you guys could work on or consider working on between now and the next call that could be really helpful is to ask your staff, how do you think we can get patients off the ventilator faster? This type of a simple question, I think, could really provide some important insights for you about what is going on in your unit, and particularly for the unit directors and your CUSP leaders. This type of a question, I think, could really share some insights into where we need to kind of focus these efforts in terms of improving patients on the ventilator. So I'm very thankful and honored and humbled to be part of such a large collaborative. Dr. Arabi and your team for pulling this together across the kingdom, I think is exceedingly exciting. We're very interested and supportive in helping the teams and whatever we can do to help support you. Please just keep those communication lines open. How we can support you. If there are steps to this CUSP program that you want to explore, I encourage you to try that. Give us some feedback. If you have questions about these CUSP steps and how these should be panning out, let's keep this conversation open and figure out how we can best support you moving forward. Dr. Arabi, any other thoughts?
Absolutely.
Asad?
No, sir. Thank you for that summary, and I concur. In fact, I believe you might be scheduled for another call in a couple of weeks, and we'd be happy to talk about some of those steps and tools that were mentioned, like how to ask people for their opinion and prioritize defects using a staff safety assessment tool, and or the learning from defects tool. We can share those tools with you to help make this a more easier experience and more uniform, and hopefully more fruitful for everybody.
Asad, you bring up a great point. So the next call then, so we can review that, staff safety assessment, how will the next patient be harmed? And the learning from a defect tool, I'll just share, is perhaps one of the most popular tools that we have, the teams have appreciated across many different projects. And in this example, for this project, we're going to apply the learning from a defect tool, or encourage you to apply this tool when patients don't get the evidence-based therapies they should, when you find a patient who didn't find a spontaneous awakening trial, when you find a patient who didn't have a spontaneous breathing trial. I think it's really important to understand why that happened. And again, this isn't about individual physicians and nurses and providers, but really starting to dig in to understand what is it about this system, the way that we've organized care delivery, that patients aren't getting the therapies they should. And how can we begin to fix that from a system level? Because again, every system is perfectly designed to achieve the results that it does. So if patients aren't getting these therapies, it's not because of your providers, it's because of the system. And we really need to develop those system levels to understand, is this a problem of awareness? Is this a problem of agreement? Is this a problem of it's just too difficult to do it? So really beginning to dig in, we'll talk about in more detail on our next call together. Dr. Arabi?
That's fantastic. I think in the meanwhile, we can circulate the Science of Safety video. So, and we'd like all the units to use that in their for their staff and use it as educational material. Also, we can put it on our website as well. So I think it's very important to do that. And we really appreciate your time, Sean and Asad, for being with us, and all the teams from all the units are participating in our webinar. I think it's been really exciting hour, and I appreciate everybody's time. So thank you very much.
Dr. Yaseen?
Yeah, I think we need to close. Yeah, Hasan.
Yeah, just 1 minute. Can we give the chance to Dr. Ali, our consultant, for 1 minute, please?
Quickly though, yeah, quick.
Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Really, it was a great experience for all of our team. We'd like to thank you all sharing such an experience, and we feel the improvement from, in fact, week 1. Things were progressing very well, alhamdulillah. So just thank you for all, and it's a teamwork. It's not one-man work. It's everybody in this unit is sharing, and I expect the things would all of the units across the country, bi'idhnillah.
Well, thank you for being with us. I think this really, we're really grateful for having you and for all the great work that's being done. So
thank you very much, all.
Great team. Thank you.